Executive Vice President of Analytics and Events, Allison Carlson, on the essential role of caregiving.
Good morning, everyone. Thank you so much for joining us today on a very packed week. I'm really excited to kick it off with all of you here in the room. It's an absolutely packed room. And following Jean Cassé, thank you so much for joining us. You know, what we hope to achieve here today is really elevating both experience, expertise, and lived experience, and finding ways to translate that lived experience and expertise into policy and action. And moving from, a few of the words that Andrew mentioned at the outset is we really want to challenge conventional wisdom and talk about those things that are underappreciated, unrecognized, and what more needs to be done to drive impact and outcomes. And so I'm thrilled to be able to moderate this conversation and start the program today talking about an issue that goes far too unrecognized and unappreciated, which is caregiving. It's something that isn't talked about often enough, but that all of us can absolutely relate to in our lives, in our work. And I think there's a lack of understanding about the degree to which caregiving that is often informal and often unpaid really contributes to healthcare outcomes and mitigates costs on the system. But we need to formalize ways to integrate caregiving into national healthcare strategies. And so that's what we're here to do today. So thank you to Nora Health for joining us. And Dr. Alam, I'd like to kick it off with you. You've worked in countries around the world from Bangladesh, India, and Nepal. And when we're trying to translate experience into action, I'm wondering if you could start us off with sharing a little bit more about the experience you've had and the programs you've had working on the ground and how you've seen caregiving really translate into impact in healthcare delivery.
Sure. Thank you, Allison, for that question and for laying the context. We started on this journey recognizing that caregivers are really an untapped resource. In households around the world, this concept that we care for the ones we love happens universally. It happens whether you're in a rural area, urban area, across contexts. But at the same time, we also see that this goes unsupported by the systems and the structures around them, especially health systems. And we see this as a missed opportunity. Of course, health systems are constrained themselves. There's nearly going to be a shortage of nearly 18 million healthcare workers by 2030. And there's many other stats, of course, that prove the point that systems are constrained and they're doing their best. And oftentimes we see, when we think about health, we think about health happening in hospitals or clinics. But really, the vast majority of health and care happens at homes. More than 80% of long-term care, for instance, happens by informal caregivers or family caregivers, whether it's a family member themselves or a loved one, maybe a neighbor or someone else who's loved by a patient. But oftentimes, again, the systems around them don't support them. So what we try to do is to partner with health systems, typically it's the government, and really integrate how caregivers can be supported within the process of care delivery. So it's not something that sits outside the system, not an extra nice to have, but really just integrated into how systems care. We do this in a few simple ways. We work, of course, very closely with our partners in identifying how does this get integrated into these care delivery systems, not just for one or two types of patients, but across the life cycle, from antenatal care, postnatal care, to NCDs and serious illnesses. And we do this in a simple way, have families be trained in healthcare facilities, and then have them be followed up at home over their phones. And one of the key elements that we try not to miss is recognizing that most caregiving happens by women and girls in the countries that we work in. More than 4 times as much caregiving hours or effort is spent by women than men. And so what we try to do in our program at every touch point is to bring men in, is to have them be trained. We invite them into the trainings that we do. We recognize that men oftentimes have access to the phones that we send the messages over, so we tailor messages and tailor content to them so that they acknowledge and understand their role in care. And there's other ways we do this too, but I'll share those for now.
Thank you.
And I'll pause there. Yeah.
Perfect. We'll dive into some of the mechanics and specific examples in a moment, but thank you for helping set the stage. And you mentioned the role of women, and Dr. Lotte, I'd like to turn to you. You have a tremendous breadth of experience in sexual reproductive health and rights, and also with your years-long career, really focused on gender and human rights in global health policy. And so when you think about caregiving, how are you seeing this manifest as it relates to women and families? And what are some of the aspects of caregiving that really are under-recognized, not well understood, and that we really need to focus on as part of this conversation?
Great. Thank you very much for that. Is that working?
Yes.
Yes, thank you for that, and thank you everyone for being here and for your interest in this particular topic. The global unpaid care economy, and this is according to an ILO review, is valued at over $11 trillion annually, which is nearly 9% of global GDP. But caregivers aren't being paid, but we do know that it is part of, as human beings, as societies, we look after each other. So there's nothing kind of really magical about this particular topic. However, I think in the moving from what happens as part of our societies to trying to formalize this as part of a health system, we really do need to be very, very clear and very careful about introducing extra gendered, very much gendered issues within this. We have to resist framing this solely as a cost-saving strategy. It does need to be paired with investment in professional care and caregiver support, so that we risk institutionalizing this notion of an unpaid, feminized labor. Caregivers are often women and face long-term emotional and financial costs. This isn't just about training, it's also about ensuring caregiving is not just used as a way of plugging holes in an underfunded system. If I can very quickly go to nursing, a nurse midwife by background. 30 plus years ago, when we started talking about bringing in traditional birth attendants and traditional healers, looking at alternative caregiving forces as part of the workforce, it was always thought of as a stopgap measure. We're only doing this until we have enough doctors or enough health systems and so on. If we are going to bring this properly into a system, we have to make sure that we anticipate what the issues are. So from my perspective within the context of WHO, we really do need to think carefully about what the evidence is to be able to back this and to be able to do it properly so that we are not introducing inequities in a system that is already inequitable, that we're not overplaying and overemphasizing the feminization of the workforce.
I'd love to dive into how to integrate that evidence into policymaking and draw on your experience a little bit more in just a moment. But first, I'm going to pick off what you said related to your experience as a nurse and a midwife. And Dr. Jubadah, I'm going to turn to you. You're the president of the Indonesian Midwives Association. And I'm wondering if you could provide a bit of perspective from Indonesia and the experience that you're having and the work that you're doing and the association as it relates to caregiving and how you're formalizing that within the context of national care.
Okay, thank you. Thank you everyone. I am Ade. I am President Indonesian Midwife Association. I'm sorry, I'm Indonesian. Baik. Saya selaku Ketua Umum Pengurus Besar Ikatan Bidan Indonesia menyikapi hal ini, bagaimana peran keluarga di dalam pembangunan kesehatan, di mana pemerintah Indonesia ini sudah membuat sebuah program dalam rangka untuk pendekatan keluarga, pendampingan keluarga, yaitu dengan pendampingan keluarga, di mana pada saat tim pendamping keluarga ini, bidan juga tenaga medis dan tenaga kesehatan berperan bukan hanya sebagai care provider, memberi layanan mulai dari masa remaja, masa kehamilan, persalinan, nifas, bayi baru lahir, balita sampai anak prasekolah. Tapi yang tak kalah pentingnya adalah di mana peran tim pendamping keluarga sebagai pendamping keluarga juga samping itu juga sebagai community leader, penggerak peran serta masyarakat. Nah, yang paling utama kita juga di Indonesia sudah ada regulasi yaitu tentang primary health care dengan nomor 43 tahun 2019 bagaimana promotif dan preventif di layanan primer dan juga bagaimana integrasi layanan primer ini juga merupakan bagian dalam rangka untuk pemberdayaan masyarakat yang di dalamnya ada posyandu, puskesmas atau juga bagaimana juga kita memberikan pengasuhan kepada keluarga dengan memberdayakan anggota keluarga. Contoh ketika mereka keluar dari rumah sakit di mana dengan menggunakan media sosial ataukah grup WhatsApp dan lain sebagainya di mana seorang tenaga medis maupun tenaga kesehatan ini melakukan edukasi kepada keluarga terkait dengan masalah-masalah kesehatan yang ada ketika mereka sudah keluar dari rumah sakit. Okay.
Thank you, Dr. Jubaida. And please, if you could please translate that for our audience.
I can share a few points from Ibu Ade. First one is actually in Indonesia health program. It has been existing a program which is empower the family caregiver. For our experience in midwife association, midwife has two roles. Number one is as a care providers, but secondly is to provide education to family caregiver. And second one is in terms of policy, Indonesia has a quite comprehensive regulation in preventive and promotion aspect. And it is already started to be integrated with the primary health care, where the family empowerment aspect is very highlighted, very focused in the policy. And also the bidan, the midwives, they are very active also in educating the family by using social media, for example, in their program.
Thank you for that. And I appreciate you elevating your experience from Indonesia, and I think it's emblematic of some of the challenges and also opportunities that others can learn from and integrate into national policy. I'd like to talk a little bit more about that formalization, and Dr. Alote, I'd like to turn back to you. You know, in the context of your work across multilateral organizations, how are you helping connect those dots from what is happening on the ground and caregiving that's happening within families to integrating that into multilateral frameworks and also national policies? How can this be more effectively prioritized?
I think, again, I will go back to the critical use of evidence in this, and I'll go from the ground, actually, person through to the policy level. So a very specific example with family caregivers, there was when I worked in Malaysia, not Indonesia, a particular case of a caregiver had come in with a family member, and the treatment, there was a really interesting discussion about, in terms of the person's treatment, whether the treatment was specifically for the person or for the carer. So it was an issue with dementia. And the treatment could have supported the patient to be as autonomous as possible. But that autonomy meant that for the caregiver, they needed to be a bit more vigilant. So from the caregiver's perspective, they would have preferred a treatment that would make the person calmer. So it is once we start talking about specifically what this means and how it is we're going to promote this within a system, we have to understand exactly what that means, so that we're not formalizing something that creates inequity within the relationship. And this is why I keep going back to that. So yes, it is, caregiving happens, but how do we make sure that if we want to formalize this into a policy framework, that we understand what it is we are moving with, that we're moving to formalize. There are real potentials and challenges here if we don't really understand what the equity issues are that we might be introducing. We need to make sure that we're not supporting governments to abrogate their responsibility to ensuring the best care for people as well. So it's absolutely critical. I'm not there, I'm totally supportive, but we need the real evidence base to make sure that the policies that then get introduced are not creating harms that we're not anticipating.
Thank you for that. And picking up on that point, Dr. Alam, in the work that you're doing at Nora Health around the world, how are you working to collect that evidence base and then partner to ensure that the experience, the evidence, and the issues pertaining to equity are in fact translating into those partnerships, into policy, into programs that get funded? How are you connecting those dots?
Thank you so much. And Dr. Lotte brings up some really important points here. To build on that, how we look at this evidence initially is to see how does supporting a caregiver, how does it actually support the patient's health outcomes? That is, of course, kind of fundamental to why the caregiver is also, performing in his or her role. And so what we try to measure is what are the patient outcomes that are actually being affected by this. And we've seen across a whole host of different patient populations, for instance, a reduction in post-surgical complications, things like wound infections, respiratory infections. By supporting a caregiver in that critical period to be able to recognize a warning sign, to be able to get them to get care at the right time, can actually bring down those complications. We've also seen a reduction in things like readmission. So people being able to catch, again, things early on, being able to go to a primary care doctor for care, perhaps get antibiotics and not needing to go to a hospital, which would then cause them to take days or weeks off of their life to be there again with their loved one, causing the caregiver additional burden. And we've even seen a reduction in things like newborn mortality, which of course is devastating and far too high in the regions we work in. So those, of course, what I just mentioned are they're evidence that supporting caregivers is a cost-effective way to improve the patient's outcomes. But I don't think it gets to exactly all of the important points that Dr. Lotte mentioned. What we try to do more and more now is measure the burden of caregiving and how much are we able to actually move the needle in bringing men into caregiving. That's something that we are trying to hold ourselves accountable to while it's early on and get that embedded within the government health system. So kind of that redistribution of just what it means to care. And there's, of course, other measures of equity. What we have anecdotally seen is that getting caregivers the support to care for the patient benefits themselves and their own health as well. For instance, we've had anecdotes several times. Of course, some of this stuff runs in the family. So things like diabetes, hypertension. When a caregiver gets trained in a hospital setting, we've seen numerous times how they are more aware of getting their own health checkups done, and again, numerous times that people get diagnosed with diabetes and then eventually on a treatment. And then we do also measure, softer items like anxiety, caregiver support measures, and see that those things reduce as well. But I do agree that there's a lot more that needs to be done, both in terms of research and evidence focused on the caregiver themselves and not just the patient, before we and as we integrate this into broader healthcare policy.
Great. And then Dr. Jubaid, I'd like to pick up with you then. In your experience and in Indonesia specifically, what are some of the lessons learned regarding how to systemically integrate caregiving into a national policy based on experience and based on the evidence? Again, I think there's a lot to learn from your example there.
Bagaimana upaya-upaya yang dilakukan, kebijakan-kebijakan yang sudah ada ini mungkin diintegrasikan dengan kebijakan-kebijakan nasional. Yang paling utama adalah dengan adanya saat ini program yang sudah dijalankan dengan adanya 6 pilar transformasi kesehatan, baik itu melalui transformasi SDM, transformasi digital, dan yang tak kalah pentingnya adalah untuk di pendampingan keluarga ini bagaimana penguatan di integrasi layanan primer ini merupakan salah satu bagian yang penting yang perlu lebih ditingkatkan. Dan tak kalah pentingnya mungkin sedikit saya izin menyampaikan bahwa dari saya izin menyampaikan praktek baik yang sudah dilakukan di Indonesia, bahwa Indonesia memiliki 17.000 pulau, kemudian Indonesia juga memiliki 85.000 desa yang tersebar di seluruh Indonesia dan 514 kabupaten kota. Ini merupakan salah satu bagaimana teman-teman kami Bidan Indonesia berada di 85.000 desa, itu bidan ada di 85.000 desa, dan dari 550.000 bidan Indonesia mereka ada di 85.000 desa, sehingga dengan demikian 70% bidannya Indonesia ini ada di layanan primer dalam rangka untuk melakukan baik deteksi dini, screening, dan juga bagaimana upaya-upaya pendampingan calon ibu, mulai dari calon pengantin kita lakukan pendampingan selama 3 bulan. Kemudian dari itu bagaimana pemeriksaan antenatal care terpadu terintegrasi antar profesi, interprofesi, ini juga dilakukan kolaborasi, dan kemudian juga bagaimana pertolongan persalinan sampai kepada pemberian KB pasca salin, ini juga dalam rangka untuk menurunkan kejadian angka kematian ibu, angka kematian bayi, dan yang tak kalah pentingnya bayi baru lahir, balita sampai anak prasekolah, ini juga merupakan layanan yang terus dilakukan. Dan bagaimana program-program ini terus dikembangkan, tentu perlu diintegrasikan dengan berbagai program lain, dan yang tak kalah pentingnya adalah bagaimana kolaborasi. Dan satu hal, Indonesia dengan berbagai macam karakteristik dan juga infrastruktur yang sangat bervariasi, ini juga penting sekali untuk mendapatkan perhatian terkait dengan yang perlu ditingkatkan adalah bagaimana terkait dengan tenaga-tenaga medis maupun tenaga kesehatannya. Mungkin itu. Ya.
It's quite long and so many points. I will try to make sure that everything is covered. Yeah, first one, I think Ibu Ade mentioned about that the existing policies have been quite promising, and it's already translated from the 6th pillar of health transformation, and it's already also directed to the integrated of primary health care, and this one is implemented in the whole Indonesia. And Ibu Ade mentioned that while the policy are quite good, programming aspect is another one to be given attention to, because any policy need to be materialized, concretized, and it is through a program. Ibu Ade mentioned the good practices that is done, a program that is done by Midwife Association. She mentioned that Indonesia is a very large country. We have 514 districts, 17,000 islands, 85,000 villages. And the bidan midwives, they are existing in 85,000 villages. So in Indonesia, we have 550,000 midwives, and they are separated or distributed to the 85,000. And 75% of midwives are existing in the primary health care in the village. So this is a very good practice according to Ibu Ade. And as she mentioned earlier, they do both care providers in a whole life cycle, from pregnancy to the elderly. And it's also the second role is to provide education, a companion to the family in the village level. They also do the screening, the preventive and promotion aspect very much. And even they continue to after delivery, for example, they also serve in the family planning aspect. Children also become their target. And this is a good program in bidan, midwives. Her suggestion is to make it better is how to integrate this program with other programs from other institution or department. And this is kind of a big main suggestion for integration in Indonesia.
Thank you for showcasing those examples. I think there's a lot you touched on there, including the distribution of care into very remote areas. And I think that's one of the challenges we'll be talking about a lot today, is how to make sure to increase access, but particularly in rural areas as well, and in the case of Indonesia, with so many islands, and being able to provide that care and integrate the care in terms of primary care as well is really important. And when we think about systemic change and greater integration, I think those are lessons we can all learn. You know, Dr. Alote, you mentioned at the outset the need for greater investment, and I think today and this week we're going to hear a lot about need for investment, need for financing, and in the case of caregiving, we know that so much of it goes unpaid. And so many countries have a limited fiscal space to invest in healthcare. And so when we think about the need and trying to formalize caregiving and integrate caregiving into a health system, from your perspective, what are the kinds of investments, and Dr. Lam, I'm going to follow up with you, what are the kinds of investments, and very specifically, the kind of mechanisms that can provide that support, both for integration and financial support for caregivers? Dr. Alote, please.
Okay.
I know that's a big question, but if you could try to tackle it, I'd appreciate it.
Financing caregiver support has to move beyond. At the moment, we've got, thanks to the work of Nora Health, there are more and more examples of how we're beginning to work to finalize, to kind of standardize this work. There's also, from my department in particular, quite a bit that we're doing on self-care interventions as well. So just recognizing the care continuum from the person to the carer and so on. But obviously, if it's going to be tied to universal health coverage, and we are going to make sure that it's formalized within it, it does need to be properly financed. In countries like I think Sweden and Japan, we're very well backed by the state, which includes paid caregiver leave, pension contributions, and so on. Obviously, for a lot of the lower middle income countries, we're not quite there yet. But at least if we begin thinking about it now through social protection and so on, we should be able to think about how we can properly finance caregiver allowances, tax credits, and so on. I do think that the public-private partnerships have a role. The private sector can be useful, although we do have to make sure that it's regulated so that it doesn't become commodified. But partnerships can be a really important part of it.
Thank you for that. And Dr. Lam, if you'd like to pick up on that, what are some of the mechanisms to formalize and institutionalize caregiving within the context of broader policies, and specifically as it relates to financing?
Sure. I think at a basic level, for instance, the work that we do at NORA, which is to support basic health skills training of family caregivers within the health system context, those budgets actually already exist. Oftentimes they actually go underspent. So things like IEC or training budgets, capacity building budgets, they can be reoriented to be more family centered rather than just health system centered. And I think that's like a shorter term reorientation that can happen now in most contexts, and how we typically finance the programs that we implement in partnership with governments. But I think, again, a lot of great points brought up in terms of what more can be done in the future. I think two additional ones to highlight is not just the formal workforce, but informal workforce, and keeping kind of caregiver protections for them. They may not be able to get the same type of protection from an employer, but somehow creating a mechanism where they also can take time off or be there with their loved ones during times of need. And then again, kind of reimbursing for a specific caregiving task. There are examples like the ones that Dr. Alote mentioned around the world, and they can be contextualized. I think with forward thinking within lower health system resource contexts, again, within a UHC context, that becomes more and more possible. So the very basic, again, can be born, we think, in the short term through these mechanisms, but there's a lot more that we can do in research for the future.
So we just have a few minutes left, so this will be a speed round, and ask you to keep the comments brief, but also really pointed and concrete. So this is the World Health Assembly. There's a real opportunity here for action, And so if there's one call to action that you could each have from this week, from those in the room, from those who are in positions of decision-making authority, what would that be? Dr. Jubadea, I'm going to turn to you first.
Yeah.
And we only have about a minute left, so if we could keep it brief.
Oke. Ya, yang paling utama mungkin lebih kepada bagaimana dukungan pemerintah, terutama bukan hanya di tingkat pusat. Mungkin tingkat pusat kita sudah sangat bagus sekali dengan berbagai macam kebijakan-kebijakan, tapi bagaimana implementasinya ketika kita mau melaksanakan peningkatan kualitas layanan ini dengan pemerintah daerah baik dan juga pemerintah di bawahnya ya, baik kabupaten kota, provinsi dan juga yang lainnya. Dan yang tak kalah pentingnya dukungan pemerintah di daerah itu juga bagaimana kami juga memerlukan adanya kolaborasi bukan hanya dengan tenaga medis tapi juga dengan tenaga kesehatan lainnya, dan diimbangi juga peningkatan kualitas ini, peningkatan kompetensi dari masing-masing tenaga medis dan tenaga kesehatan. Thank you. Yeah.
So Ibu Ade has two recommendation. While the national government support for caregiving is already in a satisfactory level, she expects more from the government, lower government level like provincial government and district government and sub-district government. So if that is also in the same level like national, that would be better for health workers to implement program. Secondly, she highlighted that how we can collaborate more with the other type of health workers, not only midwives, because that collaborations now is need to be prioritized based on the target of the government. And also the improvement of the health workers' competency is also needed to have a standard quality, something like that.
Thank you for that, Dr. Lam. And then Dr. Lote, we'll close out with you.
Sure. I think I'll start with the fact that we're all caregivers. This is something that us as humans, every one of us will experience, caring for someone that we love. And so just drawing from that experience, everyone in the room and online, bringing that into the work that we do and lead, and putting caregivers at least somewhere in that work.
Thank you for that. And Dr. Lote?
We need to make sure that that caregiving is gender transformative, recognizes caregiving as work, and challenge assumptions about who provides care, ensuring that there's male involvement in it, and make sure that it is rights-based.
Thank you for shining a light on this issue and for all the work that you're doing. We appreciate you being here. Thank you. Actually, you'll take that with you. Thank you.
Now, to talk about the healthcare workforce, please welcome Her Excellency Kumbize Kandoro Chiponda, Malawi's Minister of Health, Dr. Vanessa Carey, the Director of Global and Climate Health Policy at Harvard University's